Hello, students. Today we're going to focus on the Giddens concept of intracranial regulation, which looks at how the body maintains normal pressure inside of the skull to protect the brain function. So as you see on this first slide, there's a picture of the cranium, and inside that cranium is our brain. So the cranium, which we also call the skull, is a hard, closed space that surrounds our brain. It's more of a protector of the brain. And because this bone structure is rigid, it cannot stretch or expand. Okay, so we are going to talk today about the Giddens concept of intracranial regulation, and we will also look at the exemplars of head trauma, increased intracranial pressures, and seizures. Okay. In Giddens, under intracranial regulation, it refers to the mechanisms and conditions that affect how the brain processes information and functions inside the skull. So while the brain doesn't necessarily receive information from outside the cranium, right, such as through the spinal cord and the peripheral nervous system, those areas are not the focus of this concept. We will actually cover that somewhere else. Right? In the Giddens concept, we are specifically concerned with what happens within the cranium, okay, which means conditions that will affect the blood tissue, the blood flow to and from the brain, and then cerebrospinal fluid. All right, so for the most part, when we talk about intracranial pressure, it is the disruption of balance that can lead to these pressures increasing inside of that skull. All right, understanding the definition helps you stay focused on brain-specific conditions that guides nursing assessments and interventions. So disorders of intracranial regulation can be grouped into key categories that disrupt normal brain function. We're going to talk about impaired perfusion, neurotransmission issues, glucose regulation issues, and pathology changes that we're going to see. This does happen throughout the lifespan, but we do see it more common in certain age groups. When we talk about impaired perfusion, it says there on the slide, there must be consistent blood flow to the brain. This means that the brain needs to receive enough oxygenated blood, right, along with glucose to help our brain function optimally. So when we talk about some examples of this, it would be like a stroke, either hemorrhagic or ischemic, and we're going to talk about that next week in our lectures. We also talk about like severe low blood pressure, so hypotension, or it could be from a traumatic injury that results in bleeding or swelling within the brain. On the neurotransmission side, compromised neurotransmission happens when nerve signals are disrupted, right? So the nerves are basically what sends those impulses out within the brain and then also throughout the body. So this can occur in patients with history of seizures, or a patient that just has a seizure as a result of a traumatic brain injury. Or it can also occur in degenerative diseases like Alzheimer's. Some medications can also interfere with neurotransmitters in the brain. When we talk about glucose regulation, it is critical because the brain does not store glucose, as you learned when we talked about glucose regulation a few weeks ago. Hypoglycemia can quickly cause neurological changes, especially in children. That is why we worry about newborns who were born to moms that had gestational diabetes, because they have that high risk of having hypoglycemia after birth. On the other side, hyperglycemia during an illness can actually worsen brain injury if, like, let's say your patient were having a stroke. Pathological conditions can disrupt intracranial regulation because we know that in order for the brain to function correctly, it has to be healthy. So degenerative diseases like Alzheimer's, dementia, Parkinson's disease, multiple sclerosis. We also talk about brain tumors being present within the skull because the tumors tend to press on the brain. And then, of course, the brain is fighting for space with that tumor and the blood flow and the cerebrospinal fluid. Okay, so it impairs the normal signaling of the brain. Other things that can cause issues pathology-wise would be like inflammatory conditions. So we are going to talk about meningitis and encephalitis because they disrupt the brain function through that inflammatory process and can actually injure the brain tissue itself during this swelling. As a nurse, knowing these categories can help you connect symptoms to underlying causes. And then, of course, if you can recognize these symptoms, it helps you respond early to changes in their neurostatus. So let's talk about risk factors. We know that almost everyone is at risk for some sort of intracranial regulation problem because there are many different conditions that can affect the brain. However, there are some populations that are more at risk than others, and for the most part, risk varies by age and cause. So let's talk about our populations at risk. So we know that older adults are at risk or at higher risk for degenerative conditions like Alzheimer's dementia. Also, our elderly people are higher risk for falls, which increase the likelihood that they might fall and hit their head. Okay. When we talk about young children, I want you guys to imagine toddlers and how when they're first learning how to walk, right? Sometimes their head is bigger than their body. So they have this balance issue. And so when they're walking, right, they tend to toddle along, and of course they're going to fall and they're going to hit their head on the ground. So that increases their risk for falls and traumatic brain injury. When we talk about adolescents and young adults, they're more likely to experience injury-related intracranial problems. Usually it's like those young people playing contact sports or being struck by an object or being in a motor vehicle accident or we sometimes think that adolescents and young adults think that they're invincible and they like to do a lot of those challenges that they see. So it's the if you jump I jump mentality, or riding in their cars with no seat belts, texting and driving. That increases the risk for our adolescents who are driving, and also young adults. They tend to participate more in more daredevil activities. Um, Individual risk factors depends on the specific condition. So if you think about it, stroke risk increases with advanced age, right? Of course, a stroke risk increases if somebody has hypertension and diabetes. A stroke risk can increase if someone smokes or is obese. So when we talk about individual risk factors, it depends on the person and their modifiable or non-modifiable risk factors. Because remember, let's just talk about strokes. A stroke can happen if you are on blood thinners, right? Your blood gets too thin and you bleed into your brain, causing that stroke. So it's not just, smoking or lack of a good diet, lack of exercise. It could be your medications. It could be that you have an irregular heart rhythm. It could be that you have high blood pressure and diabetes and you're not controlling it. So those play a big factor, and that's why it is very important that we do a thorough assessment with our patients when we are um, first introduced to them. Okay, some intracranial regulation problems are related to congenital conditions. So we have patients that are born with hydrocephalus, okay, or they develop a hydrocephalus after a traumatic brain injury. Genetic and environmental factors can also increase the risk for degenerative diseases and brain tumors. So knowing who's at a higher risk helps you anticipate problems. So remember, Giddens is looking at the bigger picture of the concept, right? So if you can actually understand who's most at risk for a problem, you can perform a more thorough, focused assessment and be able to do a lot of teaching with that patient to implement prevention strategies. So moving on to assessment, and assessment of intracranial regulation focuses on objective neurological findings. Now we do an assessment with our patient and we take their subjective side of the story, right? Things that they tell us. But a lot of times our assessment of our patient actually helps us determine whether or not they are getting better or worse. So we look at findings based on the condition, right? They vary based on the patient, but the most common changes typically involve mental status and motor function. For example, today at clinical, we had a patient who was alert, somewhat oriented in the morning, but as the day went on, she kind of got more confused and a little bit more irritated. So we know that she has some sort of intracranial regulation issue, whether or not it's newer or it's just an after effect of maybe an infection. We couldn't really determine, but that's how you can see changes in mental status occur. Okay, so those will be the most common findings, but they typically vary with our patients. All right, so when assessing older adults or patients with baseline cognitive impairment, you need to determine the patient's baseline so you can distinguish expected age-related changes. So you can kind of see that if the patient is already confused, right? Think about our dementia patients. If they're already confused, is this confusion worse than what they were, right? Because that could indicate that they have some sort of an acute neurological decline that can be reversible with treatment. So let's say we have a patient that is confused and wanders, right, in our dementia unit, and he does this every day, doesn't really talk, just is, wandering about, pushing on all the doors. Well, one day your patient is very lethargic, doesn't feel good, doesn't really get out of bed, doesn't wander, doesn't do their normal thing. So that is something out of the ordinary for this patient. So then it would lead you to further assess your patient more, right? Because that's a change from their normal baseline. Mental status is a key component of an assessment. So at a minimum, the nurse should assess orientation to person, place, and time. Okay. Don't ask them what day it is if there is something in the room where, like on the whiteboard, where the date is written, because sometimes your patients can cheat. So you can ask them, what season is it? What month is it? What year do you think it is? If needed, some mini mental status examination can provide a quick standardized assessment of cognition. So a mini mental status examination typically is done by a social worker at a nursing home, just to kind of see if there's any mental status changes that are happening while the long-term resident is living there, right? Us as nurses, we do a little mini mental status examination, but we kind of tend to base a lot of our mental exams, right, to level of consciousness and, of course, orientation to self, place, time, and situation. Okay. Another thing that we use is the Glasgow Coma scale. So if you work in the hospital on a neuro unit, the Glasgow Coma scale, or if you watch TV, that's one of those things that they use to quickly assess a patient. Very objective measure of the neurological status, but it is fast because it assesses three parts. So eye opening, verbal response, and motor response. Make sure you guys know that because those are three very important assessment um, findings that can help us determine, whether or not our patient is in a coma or if they're stable. Okay. Changes in the Glasgow Coma Scale help prioritize their care and also their treatment. Okay, so when we talk about Glasgow Coma Scale, I'm going to change the slide here in a second. We know that it is very objective, right? What I see in my patient might not be what you see when you're coming on shift after me. So the best thing we're looking at is that our patients are together. We go into the room, we do one assessment together, and make sure that we are agreeing on the assessment findings. For the National Institutes of Health Stroke Scale, I want you guys to go into your med surge book and review that. That is something that we are going to cover during our classroom lectures. Okay, so the NIHSS stroke scale basically is one tool that is used to assess a patient when they're coming in with a stroke to kind of assess the severity of the patient's strokes and the likelihood of further complications. So make sure you go into your med surge book and review that page and the table. Kind of put a little sticky note on it, or you can kind of bookmark the page on your SurePath page so that we can talk about it in class with a classroom activity. Okay. All right, so the Glasgow Coma Scale, or GCS, those of you who like to watch ER, Chicago Med, The Pit, anything that has an ER, a lot of times when they bring patients in, the paramedics are talking and they're like, head trauma, or patient had a stroke, or they fell off a ladder and they fell down, found on the ground, GCS of whatever number. Okay, so this is what they're talking about, the Glasgow Coma Scale. Very standardized tool that any healthcare provider uses to assess a patient's level of consciousness. So it's not just a nurse thing. Paramedics use it, doctors use it, right? We use it to kind of measure how well our patient's neurological symptoms change over time. So we use it as a tracking tool for the most part. Commonly used with head injuries, strokes, and any patients that have decreased level of consciousness. It has those three components that I told you about: eye opening, verbal response, and motor response. So remember, when we are scoring these, they are separate, right? And then we add the scores together. So if my patient opens their eyes when I walk in the room, that is spontaneous. Your patient gets 4 points. If they are oriented, then they get 5 points, right? They can answer all your questions and they're also pretty alert. And if you say, Mr. Jones, can you raise your hand and touch your nose? And they raise their hand and touch their nose, they can obey command. So that's 6 points. So the highest score your patient can get is 15. All right. 15 means that they are neurologically intact. And the lowest score your patient can get is a 3. All right. So with a 3, it means that your patient is showing signs of very little brain activity. Okay. Because basically they're not opening their eyes, they're not verbally responding, and they have, you know, um, there's one more here under extension, right? Abnormal extension, it would be flaccid. So they're not moving at all. And that would give them 1 point. So 1, 1, and 1 equals 3 points. Your patient is not doing very well. Okay. So a score of 13 to 15 indicates mild or normal neurological function. A score of 9 to 12 suggests moderate impairment. A score of 8 or less indicates neurological injury, typically associated with high risk for airway compromise and coma. So the key here is that if you have a patient that has a Glasgow Coma Scale score of less than 8, you need to prepare to intubate. Okay, so that's that little rhymey thing that says less than 8, patient might need intubated. All right, so remember, 8 or less, severe neurological injury associated with a high risk for airway compromise, which means we have to intubate to protect our patient's airway. Okay. As I said on the other slide, right, our nursing priority here is to assess for those trend changes, not just one score. So we're going to do these multiple times. When I worked on a neuro floor, or actually when I worked on the step-down unit and we took care of neuro patients, we did Glasgow Coma Scale assessments every 1 to 2 hours if they were unstable, and then every 4 hours. Okay, so it's not just a single score. A decline in Glasgow Coma Scale, even by 1 or 2 points, can indicate that they have worsening intracranial status and could require prompt intervention. So it is possible that if your patient starts out with a GCS score of 9, right, and 24 hours later, their GCS is a 13, it means that whatever treatment we're starting, the patient is improving. All right. If you have a GCS score of 9 and 4 hours later it is a 5, it means that your patient is getting worse and pretty fast. So you need to do something about that. We talked about making sure that we perform joint scoring during change of shift so that we make sure that you are consistently giving information the same way, right? Because this is for consistency and our patient safety. Let's talk about some diagnostic tests. Okay, so some common ones that you're going to see are here on the screen. So a lumbar puncture, also known as a spinal tap. We don't really call that a spinal tap at the hospital because, you know, it's more of the medical thing. So a lumbar puncture is an invasive procedure that most often is used to detect infections and other disorders of the central nervous system. Okay, so it the thing with a lumbar puncture is that it is invasive, one, so any invasive procedure needs to have a consent form prior to the physician or the nurse practitioner, whoever is going to perform the lumbar puncture. We need to have consent, so the patient has to be agreeable to that. So typically we use this when we have a patient that has meningitis so that we can determine if it is bacterial versus viral, right? Sometimes we're looking at our patients that have hydrocephalus. If they have hydrocephalus, right, it could be used to drain off a little bit of that fluid just to kind of relieve some of that pressure in the brain, all right? A lumbar puncture is not done if your patient is showing signs of increased intracranial pressure. And that is because if your patient has signs of increased intracranial pressure, even if I take away just a little bit of spinal fluid to do some testing, we could potentiate the brain shifting. Okay, so we have to treat the signs of that increased intracranial pressure first before they do that lumbar puncture. Okay. Another common one that we're going to see is called an electroencephalography or an EEG. Okay, don't confuse this with the one for the heart. That is an ECG. All right, so this one, encephalogram, is your key word, right? So electro means electric, right? So electric means we're going to look at a graphic representation of the electrical activity in your brains. And cephalo means brain, okay? So if you can't remember either heart or brain, right? The one for the heart is called an EKG, electroencephalograph, or electrocardiograph, right? Versus electroencephalograph. So EEG is the one that looks at the activity in your brain cells. So we do that for our patients that have seizures, right? Or potential for seizures. Okay, so that's when you're going to see it. A brain scan is used to diagnose some things like an abscess, a tumor, a hemorrhage, a contusion. So your patient goes in and gets a CT scan to get that picture of the brain. Oftentimes, the first thing we're going to do when our patient shows any signs of decreased mental status, change of mental status, right? We're going to try and see what it is, or is this a brain thing? Okay, so a brain scan, a CT scan is what's going to tell us what's going on in the brain. All right, an angiography. So this picture right here that you see on the right of your screen is this right here is an angiography. So basically this is where we have dye that they put in through the arteries. And as you see the arteries, you can see all of the little brain stems. And this can find a couple things. It can find occlusions. It can find diseased vessels. So it can see the narrowing in the vessels so that we can kind of see how, if our patient has like blockages in the brain, we can kind of see how the blood flow is affecting the brain function. Okay. Let's see here. We talk about CT scans and MRIs. So a couple things about CT scans and MRIs. Remember, we need to ask our patients about their allergies to iodine or shellfish because the contrast that is used is iodine based. Okay, so we don't want them to have a reaction. Another thing with CT scans is sometimes they ask about medications. So make sure if your patient is on metformin, that we hold that medication prior to your patient getting this CT scan done. Okay. And then right at the bottom where it says Doppler flow studies, that's basically that ultrasound that they put right on your carotid arteries to see whether or not you have adequate blood flow going through those carotid arteries to the brain. Sometimes we take care of patients that have narrowed carotid arteries, so it tends to cause some confusion or some foggy brain issues or potential strokes for our patients. All right, let's talk about how this all relates together. So in Giddens, so this picture comes from Giddens, right? It says something about cognition. So intracranial regulation is affected, is one of the things can affect your cognition. So I'm always like, I always put a disease process right here. So let's put stroke. That's our exemplar. Okay, so if our patient had a stroke, does it, I should ask, can it have or damage your patient's cognition? Yes, right? Because cognition is dependent on your brain working to 100%. Okay, so if intracranial regulation is disrupted, depending on the affected area, you might have a cognitive function issue that can be either temporary or permanent. All right, so a patient that has had a stroke can result, we call it vascular dementia. It can result in some cognition issues, probably, temporarily or more permanently down the line. Okay. We talk about mobility issues. So mobility is dependent on an intact neurological system and effective intracranial regulation. So patient may become immobile if they've had a stroke. They might have balance issues. They might not be able to perform ADLs, right? Because they might have that hemiplegia, or they might not ever be able to perform purposeful movement after a stroke. So we talk about mobility being affected by intracranial regulation. We talk about gas exchange. So gas exchange is very important, right? So gas exchange and perfusion kind of work hand in hand, because in order for blood to deliver oxygenated blood to the tissues, the capillaries, the organs, it has to pass through the lungs. Okay, so neurons can't function without adequate oxygen and nutrient-rich blood. So if we have, poor gas exchange or poor perfusion, we're going to affect our intracranial regulation. Okay. And then, of course, we talk about hormonal regulation, but this hormonal regulation has to do with the hypothalamus and the pituitary gland. So if we have some um, damage to the brain tissue, it can interrupt normal hormonal regulation because of the location of these glands. And you're going to learn more about these two glands in fourth term. Okay, so keep that in the back of your mind. All right, let's move on to head trauma and increased intracranial pressure. So when we talk about head trauma, okay, in your med surg book, it defines head injuries and it says that it can range from mild to life-threatening. All right. When we talk about head injuries, it can also affect the scalp, the skin, or the brain tissue. Okay, so in the classification, scalp injuries include lacerations, abrasions, right, cuts and bruises, hematomas. So those are my fancy words for cuts and bruises are lacerations, abrasions, contusions, and hematomas. These injuries tend to bleed pretty heavily, but may occur with or without deeper brain injuries. Okay. So careful assessment is needed. So if someone falls down and bumps their head, right, and they get a cut or a laceration, they might bleed pretty heavily. Okay. But you also need to, you need to stop the bleeding or put a pressure bandage on it like they did to this poor guy in this picture. And then you need to assess further, right? You need to do a neuro assessment. Okay. A concussion, we call that mild traumatic brain injury, occurs when the brain is shaken inside of the skull. So can happen from a fall, can happen from a motor vehicle accident, right? Remember, they call it whiplash, where if you get hit from behind in a car, your head jerks forward, so the brain propels forward and hits the front of the skull, and then of course you whip your neck backwards, and so they hit the back of the skull. So that's why we call it a concussion. Okay, and also occur with sporting activities, or if you were jumped from behind and somebody hit you on the side of the head, right, an assault. Common symptoms of a concussion are confusion, headache, nausea, dizziness, and some memory loss. Sometimes there's a brief loss of consciousness. Okay. If there is a loss of consciousness, patients need to be observed for at least 24 hours for worsening symptoms. Okay, so if they had some confusion, headache, dizziness, those are typically early signs of increased intracranial pressure. If your patient has a worsening headache with some vomiting, confusion, difficulty walking, that is more worsening symptoms of that concussion. Your patient will need to return to the ER. They don't typically, if it's a mild concussion, they scan the head, make sure there's not any further like bleeding or injury within the cranium, and then they typically will discharge with instructions to watch the person for 24 to 48 hours to make sure that their symptoms don't get worse. Okay. A contusion is more serious than a concussion because it involves bruising and bleeding of the brain tissue. Symptoms depend on the area of the brain affected. Sometimes it could have some neurological deficits depending on where this bruising is on the brain, and it tends to resolve slowly as the brain heals. Okay. Hematoma is fancy for collection of blood, right? We call hematomas typically caused by we have two categories. We have subdural hematomas caused by venous bleeding, develops pretty slowly. Um, it's like a little small leak of your vein in your head. Typically happens in our older adults. Okay, so subdural hematoma, venous bleeding. Okay, epidural hematomas are typically arterial bleeding. They're known for brief loss of consciousness, rapid deterioration. They might be pretty lucid, like they know what's going on, and then all of a sudden it's like a very rapid decline. Okay, so a subdural hematoma, an epidural hematoma, both medical emergencies, both require your patient to go to the ER to have the blood evacuated and the bleeding stopped. Okay. An intracerebral hemorrhage occurs when the brain tissue itself can cause severe there's bleeding within the brain itself. Okay, causes severe neurological deficits until we stop that bleeding, right? The longer that bleeding goes on, the longer the hemorrhage is, the more potential it is for cerebral edema, so brain swelling, and it can cause very, very long-term effects when it comes to hemiplegia, your patient talking, those facial drooping. So it's a very serious stroke for our patients, okay? Typically, the only way to relieve an intracerebral hemorrhage is to go to surgery and evacuate the blood, stop the bleeding. All right. And then we talk about penetrating injuries. So penetrating injuries occur when an object pierces the skull and the brain. All right. These injuries require immediate surgical care, and they have a very high risk for infection, right? Because if you fell and you had actually, let me think of another one. So your patient had a gunshot wound to the head, right? So that penetrates into the skull and it might damage the brain or it might not damage the brain. But if your patient is still alert and awake, they need to go to surgery right away. We can't just stop them in the ER at triage because we're increasing the risk for our patient to bleed out and we're increasing the risk for infection. So they have to go and have surgery right away. All right. So remember, rapid intervention, typically critical to preventing increased intracranial pressure and permanent brain damage. The most common ones that you guys are going to witness would probably be concussions and scalp injuries for the most part. And of course, if you're taking care of stroke patients, we're going to talk about them next week. You're going to see some patients that have hemorrhagic strokes, so they're having brain bleed, or you're going to see patients that have ischemic strokes where it's caused by a clot or a narrowed art vessel that got occluded. Okay. So treatment of head injuries focuses on preventing further brain damage and maintaining adequate intracranial regulation. Surgical treatment may be required to remove hematomas or damaged brain tissue to relieve the pressure within the cranium and prevent worsening neurological injury. As for nursing priorities, one of the biggest one is maintaining cerebral perfusion. So you have to assess your patient closely for early signs of increased intracranial pressure. So as you see there on the screen, we're going to look for a decreased level of consciousness, restlessness, pupillary changes, vital sign changes. Okay, so we're going to make sure that we are looking at signs that you have increased intracranial pressures, because that will direct you into what to do next. All right. Oxygenation is another priority. So we monitor O2 sat and breathing patterns. And of course, we always report signs of respiratory depression immediately. Make sure you guys review your SurePath reading. In the area around increased intracranial pressures, because you guys will be responsible for knowing how a head injury um, affects your vital signs. Okay, so like a temperature might go up, your blood pressure might elevate, your heart rate might drop. So make sure you're reviewing in your readings um, the area regarding increased intracranial pressures. Okay. We talk about patients being at risk for injury. So you need to watch for dizziness, confusion, poor coordination, and definitely make sure we are assisting with mobility and toileting. Okay. Because these head injury patients often have wounds and they might have invasive lines, you need to be able to prevent infection. Remember, nowadays we have enhanced barrier precautions. So we are preventing infection by, putting on a gown, putting on gloves, putting on a mask to make sure that we aren't increasing the patient's risk. Okay, so we try to do that when we have wound care. Sometimes these patients will have ICP monitors in their head, and that's a very sterile wound dressing because it's actually got direct access to the brain tissue. Okay. Mobility support is essential, so you need to reposition your patient and protect skin integrity. Remember, a lot of these patients with head injuries will have some mobility limitations during the acute phase, so we have to make sure that we are preventing skin breakdown so that they aren't at risk for infection. Also, and of course, you need to, if they are alert, encourage deep breathing and coughing so that they don't get pneumonia. We talk about range of motion exercises, right, so that they don't get stiff. And of course, making sure we monitor for bowel and bladder function to make sure that they don't break down if they're incontinent. Okay. So along with head injuries, we're going to talk about increased intracranial pressure. So increased intracranial pressure is considered a medical emergency. When the pressure rises inside the skull, blood and oxygen delivery to the brain tends to decrease. So early recognition of signs and symptoms of increased intracranial pressure is very critical to prevent permanent brain injury or brain death. Okay, so remember, increased ICP, life-threatening neurological emergency, right? Um, when we talk about increased intracranial pressure, I want you guys to look at this picture. It's called the Monroe-Kelly doctrine. Okay, so I want you to know that within the skull is the brain tissue itself, the blood, and cerebrospinal fluid. Okay, so um, if one of these components increases, such as swelling, right, or bleeding, the ICP rises. So intracranial pressure rises unless the blood or the cerebrospinal fluid decreases. Because remember, the skull is rigid. There's no room for anything to expand, right? It kind of contains everything within its space. Um, when we have a rise in the intracranial pressure, cerebral perfusion decreases. So the blood flow to the brain will drop, which leads to less oxygenated blood, which leads to ischemia. And ischemia means that there might be death of that organ tissue. Okay, so normal intracranial pressure is anywhere between 0 to 15. Okay. When we take care of a patient that has head injury, that's why we do that Glasgow Coma scale assessment, because we are kind of looking at neurological changes that um, can help us treat our patient faster and prevent further complications. That's what you're looking at with increased intracranial pressures. The earliest and most reliable sign of increased intracranial pressure is a change in level of consciousness. Okay, even subtle changes matter. So as pressure worsens, you're going to have changes in your pupil response. You're going to have motor deficits. You might have some abnormal posturing. So decerebrate and decorticate posturing. Make sure you guys are looking in your workbook. At what those signs are. So when we talk about decerebrate posturing, that is where when you elicit a pain response, so I rub on my patient's sternum, your patient will extend their fingers and they will extend their toes and they'll get really stiff. So it's just like they're reacting to you by stiffening. Okay, that's decerebrate posturing. So all extension, all those E's in decerebrate, you should be thinking extension. Then we have decorticate posturing. So that is when I do a sternal rub, right? My patients will draw inward. So they're going to draw their arms into the middle. So that is the core, right? So I'm always like decorticate, the patients draw to the core and their feet kind of cross over each other. So they're bringing everything to the middle. Okay, so that's decorticate posturing. When you see that, it could indicate further, it kind of just indicates, how much brain injury is happening and how much pressure is within the brain. So it could just be that they have cerebral edema and there's nowhere else for that brain to swell and we need to do something, right? Because if you have something called Cushing's triad, right, very late sign that something is going to happen. Okay, it often indicates that the brain is going to shift within that skull. We call that herniation. So it can shift to one side, it can shift out of the hole at the bottom of the skull. For Cushing's triad, you should know that what you're looking at is an increase in the systolic blood pressure, right? So systolic means the top number is the one that's elevating. The diastolic number is staying the same or close to the same. The heart rate starts to decrease, so it starts to get slower, and then the respirations start to get more irregular, right? So sometimes it'll get fast and irregular, sometimes it'll get slow and irregular, but it will get more irregular as the blood pressure increases and the heart rate slows down. Okay, so typically one of your very, very late signs, and if you don't do anything about it or if you don't recognize it, your patient will actually code, right? They will pass away. So let's talk about clinical management. So these are all interventions that we do to help lower the intracranial pressure. Okay, so refer to Giddens, page 124, for some, readings on these interventions. Okay, so the goal is typically to reduce the pressure inside the skull while maintaining adequate cerebral perfusion. So we want to make sure that we're still getting good blood flow, right, while your patient is trying to heal. So positioning is one of the most effective interventions that we can do, elevating the head to about 30 degrees. So no more than 30 degrees, okay? It promotes venous drainage from the brain and helps lower the intracranial pressure. Very essential to keep the neck and the head in the midline, so in the middle. Okay. And then, of course, you kind of have to watch your patient's neck flexion because it might compress the jugular veins, which can increase the intracranial pressure because the blood isn't draining from the brain. Okay, so positioning should be used as long as cerebral perfusion pressure remains adequate. We talk about activity management, which is important. So making sure that we do things for this patient spread out over a period of time. So clustering too many activities at once can cause an increase in the oxygen demand. So it will raise the intracranial pressure. So you should space it out to allow the brain to recover a little bit. So for example, you are giving your patient, Mr. Jones, needs to have his morning medications. He needs to have a bath and he needs to be dressed and ready for therapy. Okay, so you can, in a healthy patient, we can do all three probably at the same time, and it'll take us a half hour to 45 minutes. For a patient with increased intracranial pressure, we might want to do their bath first. Give them about 30 to 45 minutes to recover. Um, bath, we put a new gown on them, and then let them recover, and then come in and do their medications, and then wait 15, 20 minutes, and maybe then sit them up in the chair, right? We can't do it all at once. You should be doing it a little bit at a time. It allows the brain to recover between the activities. When we talk about airway management, this kind of requires caution. So coughing tends to increase your intracranial pressure. Those of you who have been sick and you've had the flu and you're coughing, remember you get a little bit of pressure on the side of your temples. So the same thing happens to our patients that have increased intracranial pressure. Suctioning, right? Suctioning kind of triggers the cough reflex. So suctioning should only be done as needed. Okay. That's the key word. If you have a patient that has increased intracranial pressure, you should be suctioning as needed, not every 2 hours, not every hour, because you're going to elicit that cough mechanism. You're also lowering the patient's oxygenation while you're suctioning. So, you will increase their pressures the more you do it. Okay. We talk about hyperventilation. We don't really use this routinely. Typically, a temporary emergency measure to decrease ICP because we're lowering carbon dioxide that causes that cerebral vasoconstriction. So basically, we're causing the vessels to open up a little bit so that we have more chances to decrease that ICP, but we don't use it very often, okay? Because prolonged or aggressive hyperventilation can actually reduce cerebral blood flow, which is working opposite of what we're trying to do. Okay, so we're only using it as an emergency thing. Sometimes they use it when you have to suction your patient, so we give them a little bit of extra oxygen before we go in and suction our patient. Okay. Bowel management is very important because we don't want our patients to strain when they're having bowel movements, especially in times where their intracranial pressures are elevated. Okay, so stool softeners and laxatives are typically used to prevent constipation for these patients. We talk about your cerebrospinal fluid drainage. Can be used when ICP is monitored invasively. So this is only done when we have that ICP monitor. It can basically remove excess cerebrospinal fluid to help lower ICP. Okay. If our patients have hydrocephalus, then sometimes a shunt can be placed to help decrease the ICP with those patients. Okay. All right. Any questions? So I wanted to show you this chart because this chart helps you kind of lay it out, so that you don't get confused with head injury versus increased intracranial pressure. So when we talk about head injury, I want you to think of it as the cause, right? And the cause is, it could be trauma, it could be something penetrating, it could have been a sports injury, but the cause is what causes increased intracranial pressure to happen, right? So when we talk about your intracranial regulation, what happened to increase your patient's intracranial pressure? He got a concussion. So always think head injury is the cause, increased ICP is the complication. So when you have increased ICP, right, your priority starts to turn to airway, positioning, and neuro status of your patient, right? So kind of take a look at the slide and just kind of compare, right? Head injuries cause is an external trauma. The result of the external trauma is a rise in the pressure inside the skull, right? Hopefully the visual helps you a little bit. All right, let's move on to seizures. So a seizure is a sudden change of behavior caused by abnormal electrical activity in the cerebral cortex. Okay. Normally, electrical impulses in the brain travel in an organized and very controlled pattern, but during a seizure, the impulses tend to become uncontrolled and chaotic. That leads to abnormal movements, sensations, behaviors, and changes in level of consciousness. A seizure involves many neurons firing at the same time, which increases the brain's demand for oxygen and glucose. So, because the brain cannot store either oxygen or glucose, right? I want you to know that prolonged or repeated seizure activity can deplete oxygen and glucose, which increases your patient's risk for further neurological damage. Okay. Seizures, especially those that occur a long time, they're called status epilepticus, we'll talk about them in a minute, are considered a neurological emergency. Okay, so, and it always requires prompt assessment and intervention because one, it is something that can damage your brain, plus it impacts your patient's safety, and it can also impact your patient's gas exchange, right? The breathing portion of not even the airway, but breathing for the most part. So we're making sure that we're assessing these patients as fast as possible. Seizure activities can occur for many different reasons. Your patient doesn't have to have epilepsy to have seizures. Make sure you guys know some of the common causes. We talk about head trauma, right? Reduced cerebral perfusion, so your patient had a stroke. It could be an infection. It could be an electrolyte imbalance. Low sodium is one that comes to my mind. It could be medications or drugs. It could be that your patient has a brain tumor. It could be that they have some sort of a genetic predisposition, right? So make sure you guys are reviewing the different causes of seizures because it can happen at any time. I know like people with like seizure-like activities, right, could be a result of a migraine. It could be a result of a TIA, a temporary stroke. It could be a result of sleep loss. I know that one of my students from many, many terms ago, she had a head injury from a skiing accident, and the result of her head injury was her having seizures. She became epileptic after that, and so had to be on medication. So she was pretty healthy all the way up until that, that accident with the traumatic brain injury, and the result of it was her having a seizure disorder from her head trauma. So it can be caused by anything, really, not just you were born with a genetic predisposition to have seizures. In Saunders, in your Saunders book, the Silvestri NCLEX PN book, you should review page 832. It talks about the seizure activities. Seizure activities occurs in many different stages, so not every patient will experience every stage. So as you see here on the slide, there are 4 stages that you see, right? The prodromal phase occurs hours to days before a seizure. Patients may report like mood changes, irritability, anxiety, tiredness, right? A headache. Serves as an early warning to that person that a seizure activity might occur. Remember, some of these patients, if they have them all the time, they kind of get that feeling before it happens, okay? An aura is the first part of a seizure and is considered a focal seizure. So many patients experience sensory changes. So sometimes like an unusual smell, a taste, visual disturbances, they have some sort of a warning sign before the seizure actually happens. Okay, so prodromal, they have this like, I have a bad feeling something is going to happen, and then they get this aura that happens right before, right? Sometimes the patient's typically conscious, so they can go and lay down and put themselves in a safety position before the big seizure happens. Okay. The ictal phase is considered the actual seizure activity. This may include loss of consciousness, muscle rigidity, rhythmic jerking, altered awareness, or behavioral changes depending on the type of seizure that's going on. But during this phase, the brain has a very high demand for oxygen and glucose. So we definitely need to make safety and airway protection our priority. Okay. After the seizure, it's called the post-ictal phase. Patients typically might be drowsy, confused, they're weak, they're complaining of a headache. They might have some temporary paralysis or speech difficulty. We talk about recovery time being like a couple minutes to a couple hours. So as a nurse, if you have seen a patient have a seizure, you need to monitor this post-ictal phase, right? Kind of time it out so that you can let the physician know how long it lasts. I call it like the reset phase. So like it's like your phone isn't working, so you turn it off and you turn it back on and then it resets itself. This is what this post-ictal phase is doing. Okay. Um, if you can kind of ask your patient a lot of times when they have a seizure, right? In this post-ictal phase, when they wake up and they kind of start realizing what's happening, you can kind of do a little bit of an assessment. Like, did you have any warning signs before you knew this seizure was happening? Some patients do have warning signs and they do remember these warning signs, so they can help you with that. We have a couple seizure types that we're going to talk about. So focal seizures are classified according to whether or not there is a loss of consciousness during the event. Remember, I told you just a little bit ago about the aura and how that can be considered a focal seizure because it's like a partial. It's giving you this warning sign, right? We call it focal seizures with impaired awareness most commonly occur with people who have epilepsy. And focal seizures with retained awareness, that's people that, don't lose consciousness. That varies according to the area of the brain affected by the onset of a seizure. So this is where your aura comes in, right? They don't have any level of consciousness change. They just kind of get more super aware that something is going to happen. Generalized seizures, on the other side, involve the entire brain from the onset and are associated with loss of consciousness. Okay, so we have tonic-clonic seizures. That is where you have this rhythmic jerking and stiffening. A lot of time we called it the grand mal seizure, right? They just renamed it. So if you can remember it as the grand mal seizure, that's what this is. So stiffening and jerking at the same time, often a loss of consciousness, and then post-ictally, they'll have some confusion and some fatigue, right? Because like you're stiffening and using all of your muscle. Absent seizures occur typically in children. Okay, so this is where if you were talking to this person and they were talking back to you and then all of a sudden they stop talking, right? They start staring and then it looks like they're kind of daydreaming and then they kind of snap out of it and carry on like nothing ever happened. Okay, so that's an absent seizure. Like I said, more common in children. If a child does have this, it could progress to them having more of the normal type seizures that we see. They don't tend to outgrow it. Okay. A myoclonic seizure, the patient only has brief jerking or stiffening of the extremities. So it could just happen in like my one shoulder or my one leg, but it's just a very brief jerking. An atonic seizure, we call it a drop seizure, have the opposite effect of tonic seizures. So they have a sudden loss of muscle tone, especially in the legs, and then your patient will collapse. So that's atonic. Okay, but the most common ones that we're going to see are your tonic-clonic seizure, your absent seizure, and your myoclonic seizures. With seizures, we have something called status epilepticus. So in your Linton book, in your med-surg book, it describes status epilepticus as a continuous seizure activity greater than or equal to 30 minutes. Okay, or a repeated seizure without regaining consciousness. So status epilepticus is life-threatening. Okay, this seizure continues or is repeated without return to consciousness between episodes. And it is very important that we do something about it because remember, um, the, the brain needs oxygen and glucose to be able to work properly. And when your patient is having seizures back to back to back to back, they aren't able to take in deep breaths to get oxygen in. Okay, so a very high risk for permanent brain damage if we let it continue. Okay, this tends to happen in our patients who are having withdrawal symptoms, right? Seizures is one of those side effects or things that happen when people are withdrawing from alcohol, drugs. And so we monitor them very closely for their seizure activity. Okay, so we try to medicate them so that they don't go into the status epilepticus stage. Requires an immediate treatment, which focuses on airway, breathing, and circulation. So priority is to maintain a patent airway, typically by turning our patient on their side, right? The next thing we do is to administer a benzodiazepine, so either lorazepam or diazepam, so Ativan or Valium, which will stop the seizure activity rapidly. All right. If it ends up slowing down, that Valium or the Ativan starts to slow down the seizures and your patient continues, then they will get a seizure medication, right? So like for Dilantin, that might be administered. But typically Ativan is enough to just slow it down so that your patient can have time to stop seizing. Okay. So at the same time your patient is seizing, you need to think about what else could cause the seizure from happening. So think about things that you can fix. Low blood sugar, right? Electrolyte imbalances. Your patient might have a head trauma. It could be an infection. If you can figure out that this seizure, because it's continuing, is caused by something you can reverse, treating the problem will stop the seizure, right? We're going to give them some Ativan to stop the seizure or try to slow down the seizure, but you should think about what else could be causing this seizure. So your patient might have had a head trauma and now they have increased intracranial pressures, so they're seizing because of that. When we talk about diagnostic testing for seizures, it typically focuses on identifying the cause and type of seizure and ruling out underlying problems. A detailed history is one of the most important diagnostic tools for anybody. Information about what's happened before, during, and after the seizure can provide valuable clues about triggering factors, the type of seizure, and where the seizure activity originated from in the brain. Because seizures often occur unexpectedly, nurses and family members are frequently the first witnesses. So if you observe a seizure, you need to document a couple things. What the patient was doing or what their behavior was before the seizure, what occurred during the seizure. So basically, what did that seizure look like? The patient's condition after the seizure, the duration of the seizure, and the duration of that post-ictal phase. Okay. Sometimes they want you to know whether or not that patient was continent or incontinent. An EEG, right, an electroencephalogram, is a key diagnostic test. It is used to record the electrical activity of the brain and helps detect the abnormal brain waves associated with seizure disorders. So accurate observation, documentation, and testing help guide diagnosis, treatment, and management of the seizures. So some medications, okay? There's a lot of medications in your workbook. There is a chart that says there's a list a couple of medications that you should work on. One of the things that you should look at is reviewing table 22.2 in your med surge book. Okay, that's on page 384 to 386. There's a list of medications that could possibly be used for seizure activity in your patient. Another thing that you need to focus on, because these medications require to have a certain level of medication in the blood, you need to look at reviewing the therapeutic levels for these. So in your Saunders and Kleck's book, there's a link to it in your SurePath, right? There is a table that has the therapeutic levels for your most common seizure medications. Okay, so make sure you review those. Very important, because if your patient is, over therapeutic, they're going to start showing signs and symptoms that they have too much of this medication on board. And if they are subtherapeutic, so they don't have enough of this medication on board, they are going to have what we call breakthrough seizures. Okay. The dose of the medication is gradually increased until a therapeutic level is achieved. So for the most part, they start at the lowest dose possible to try and see if we can control the seizures with as little medication as possible. Okay, sometimes one medication isn't enough. So oftentimes you're going to see a patient on phenytonin, which is Dilantin, and valproic acid, which is Depakote. So sometimes they're taking those two medications together. It just depends on the cause of your patient's seizures as to whether or not they're going to be on one or more medications. Okay. We always educate our patient, as you see there on the screen in red, that they should not suddenly stop taking their anticonvulsants because it can lead to seizure activity. All right, so on this slide, there are 4 medications here. These are the 4 medications that you will see on your med sheet or in your workbook on the boxes for the medications, along with Ativan. So I left Ativan off because I know that it is also in your 172 workbook. Okay. When we talk about phenytonin, also known as Dilantin, it works by reducing that neuron hyperexcitability, which helps prevent seizure activity. So most commonly used for focal onset seizures and can also be used to reduce pain in your trigeminal neuralgia. Okay, so one of the things I want you to look at is that one of the common side effects, right, could, because it involves the nervous system, it could include ataxia, which has something to do with walking and balance. Okay. Um, Also nystagmus, which has something to do with your patient's eyes. So your patient is at increased risk for falls or injury if they're on this medication. You should note that falls and injury is one of the side effects that are most common with Dilantin, along with something called, with long-term use, they could have gum overgrowth, right? Um, so we have to make sure that our patient has good oral hygiene. All right. One of the things you need to remember that if a patient has tube feeding and they have to have Dilantin, you need to hold the dose, right? You need to stop the tube feeding 30 minutes before you give this medication, and then you have to wait 30 minutes after you give this medication before you start that feeding again. Okay, or you need to time the Dilantin um, away from feedings. A lot of times we just hold the tube feeding for an hour before we give this medication, and then we hold the tube feeding for another hour, giving the medication time to absorb in that GI tract. Okay, so that's one of the things that you need to remember. And of course, oral care. Another medication is valproic acid. We call it Depakine or Depakote, anticonvulsant that is used to control seizure activity. All right, you see there it says increases GABA. GABA is something that kind of helps decrease the excitability of the brain, so that way it stops or decreases the amount of seizure activity you're going to see. Okay, we talk about your medications being used to treat tonic-clonic seizures, partial seizures, and myoclonic seizures. So this is one of those medications that you're going to see. It's very frequent, comes in Depakote or Depakine, it doesn't matter, but valproic acid is the generic. So phenytonin and valproic acid, two of the more common seizure meds that you're going to see used. We do have common side effects, right? Just like our phenytonin, dizziness, headache, ataxia, which increases the risk for falls, can cause their hair to fall out. That is alopecia, which is probably distressing for the patient, right? But you should let them know that that is going to happen, and they could gain some weight. Um, carbaz carb I always just call it Tegretol because I can't say it just like you guys. Works by slowing down the transmission of nerve impulses in the central nervous system. Common side effects, drowsiness, dizziness, but you should also watch your patient for mood changes. Okay. Um, when we first start this medication and when they are like adjusting the doses of the medication tends to increase your patient's risk for falls. So you need to kind of watch your patient for falls. So this medication can has an effect on the cardiovascular system. So it can increase or decrease the blood pressure and in some cases worsen heart failure. Okay. So things that you need to know is that with Dilantin, gums, right? Gums, you need to brush your teeth, have good oral hygiene, and then we look at their gait, ataxia. Okay. For valproic acid, we look at platelet count, okay, because it can decrease their platelets. You also need to watch for signs and symptoms of increased bleeding because of that low platelet count. For Keppra, it can increase behavior and mood changes. So irritability and depression is one of the things that you're looking for. And then, of course, Tegretol, we are looking to monitor those blood counts because you have a risk of aplastic anemia, which kind of breaks down your red blood cells. When a client is having a seizure, the priority is airway, breathing, and circulation, in addition to safety. Remember, airway is typically always first. First, maintain a patent airway so we don't force the jaws open, we don't place anything in their mouth because this can cause injury. Okay, you need to note the time and duration of the seizure as soon as it begins. If the client is standing or sitting, gently lower them to the floor, protect the head and body, and loosen restrictive clothing. Make sure to turn them onto their side to allow secretions to drain and reduce the risk of aspiration. Once the seizure is done, administer oxygen and be prepared to suction secretions if needed. If your patient is wearing oxygen, just make sure that they're safe and they don't get hung up on the oxygen tubing. During the seizure, do not leave your patient, do not restrain them, and focus on preventing injury. Okay. Observe and note the type, the character, the progression of movements, whether or not your patient had an aura, whether or not they were incontinent, and if ordered, did you administer medications to stop the seizure? Okay. After the seizure, assess the postictal phase, which includes level of consciousness, motor function, and speech. Make sure you provide privacy, ensure their patient safety, and of course, making sure you go back in and reassess your patient. Okay. For client teaching, you need to reinforce the importance of lifelong medication adherence so that they have a normal life. Make sure they follow up on blood level monitoring to make sure that they are at therapeutic levels. They should avoid drinking alcohol. They should avoid excessive stress and, of course, strobe lights that can trigger them to have seizures. And, of course, they need to always wear their medic alert bracelet, right? We can refer them to, foundations like the Epileptic Foundation so that they can have support systems. Okay, so for our wrap up, today we focused on conditions that disrupt intracranial regulation, which include head injury, increased intracranial pressures, seizure, and seizure management. Okay, so on this slide here is our review. The skull is a rigid structure, so any increase in brain tissue, blood, or cerebrospinal fluid raises the intracranial pressure. Okay, increased intracranial pressure is life-threatening, and the earliest and most reliable sign is usually a change in level of consciousness. As ICP worsens, we might see pupillary changes, motor deficits, abnormal posturing, late vital sign changes, which includes Cushing's triad. And remember, Cushing's triad is when you have an increase in the blood pressure, a decrease in the heart rate, and irregular respirations. Okay. Nursing interventions to lower ICP focuses on positioning, airway management, activity, spacing, bowel management, cerebrospinal fluid drainage, and medication therapy, including mannitol and Decadron. Elevating the head of the bed to about 30 degrees and making sure we keep the head and neck midline. We need to limit suctioning to as needed, and of course, administer medications to help prevent constipation and straining. We reviewed head injuries ranging from concussion and contusions to hematomas and penetrating injuries. A key distinction is that head injury symptoms can stabilize, but progressive neurological changes can signal increased intracranial pressures and require immediate action. So we're always doing a neuro assessment on these patients with head injuries. When we discuss seizures, they are caused by abnormal electrical activity in the cerebral cortex. Seizures greatly increase the brain's need for oxygen and glucose, and prolonged seizures can cause permanent damage. So status epilepticus is your neurological emergency, which requires immediate airway support and medication therapy. Nursing care during a seizure prioritizes airway protection and injury prevention. So never restrain the patient or place anything in their mouth while they're having a seizure. You need to observe the time the seizure started, how long the seizure lasted, and document what that seizure looks like. You will need to assess your patients during the post-ictal phase for how long that phase lasts. Diagnostic evaluation relies heavily on eyewitness descriptions of your patient seizures, the EEG, which records the electrical brain activity. And then finally, we reviewed your anticonvulsant medications. Make sure you review that and fill in the table that is in your workbook. Key nursing responsibilities include making sure that your patients follow up for labs so that we know that your patient is in that therapeutic range. We assess for medication toxicity, and we definitely do a lot of patient education on medical management. Okay. Make sure you know some of your patients or some of the medication side effects so that we can teach our patients what to look out for. Okay, so as a nurse, your role in neurological care is definitely making sure that we catch the changes early, because when we recognize these changes, we prevent complications and make sure that our patients are safe and are able to manage their disease process. Okay. Prompt interventions can prevent permanent neurological injury and actually can save our patients' lives. If there are any questions, make sure to reach out to your faculty. Make sure you guys are reviewing your readings that are given to you in your SurePath, and come to class prepared to do some fun activities.